Skeleton crew tonight. Okay, Zoom people, can you hear me?
Yes.
Audrey, do you have an update for us?
Dad is now on a ventilator.
Dad's on a ventilator.
He is at I'm not sure what his O2 stat is, but the air he's getting is 60% oxygen. So he was at 100 when they first put him on. He's been on for a couple days now. So 60 is about as low as it's been.
So that's progress, right?
Yeah, it's progress. We're just praying for more progress and hoping that he comes off it.
Okay. What does other numbers look like?
Well, I don't know. My mom's the one who's calling his nurses and stuff, so I haven't really asked about that.
Okay. Yes, Emily, that's your hand. Okay, well, keep us posted, and we love you. We're pulling for you. We're praying for you, and we're thinking about you often, right, gang?
Thank you. I appreciate that.
You're very welcome. In fact, my wife called me late last night. She was at her cell group, well, her rooted group, and she said, "What's the name of that student of yours whose dad's in the hospital?" I said, "Audrey Morris." And then I hear her scream over the phone, "Her name's Audrey Morris." I said, well, are they taking prayer requests? She said, "Yeah," and I couldn't remember your student's name. So that whole group prayed for your dad for like 15 minutes last night. So
that's awesome. That's exactly what he needs.
well, they'll keep doing it. So be encouraged, okay? Be encouraged. Okay.
Yes, thank you.
On the subject of encouragement, let's talk about asthma. Okay, that's a terrible lead in, but I couldn't think of anything else to lead in. Very good. Let's go ahead and start with a word of prayer. Father, we are very grateful for today. Thank you. We didn't get the rain we've gotten the last few days. Bit colder this week, but thank you for every person here, for those on Zoom. We want to continue to lift up Mr. Morris, and that you would continue to heal him, bring his lungs back to good working condition, drain them of the fluid and the filtrate and the white cells, and help him, Lord, walk out of that hospital on his own power. Thank you. Audrey can be there with her family, and Lord, do heal him. And now, Lord, guide us tonight. Help us get through things efficiently, expeditiously. In Jesus' name, amen. Okay, so asthma is an obstructive disease of the respiratory tract. Now, asthma is different than seasonal allergies. Don't confuse the two. Asthma can be triggered by allergies. It can be triggered by allergies, but they're not the same as seasonal allergies. Let's see. Abby, seasonal allergies. Give me a Reader's Digest definition of seasonal allergies.
Just like the pollen and stuff in the air, like it could be both for the pollen,
Exactly right. That's not asthma. Yes, you may wheeze. Yes, you may cough and sneeze. You might even have some trouble breathing, but it's not the same as asthma. So they are different, but they can be linked, but they're not necessarily linked. You can have a patient who has even bad seasonal allergies, but they don't have asthma. Yeah, asthma is a bird of a different feather. All right, so you get some sort of antigen, you respond to it with a heavy Th2 rich response. We talked about that last time. When you get sensitized to it, when you're exposed to it again, the Th2 cell makes these 3 cytokines, interleukin 4, 5, and 13. 4, 5, and 13. This is important because these are going to be targets for some of the treatments we're going to see a little later on. IL-4 will cause B cells to isotype switch and make predominantly immunoglobulin E. Immunoglobulin E. Immunoglobulin E will play a very important role in asthma. Interleukin 5 is a pro-survival. You see this, or is the glare on there bad as it is? It's fine? Okay, then I won't worry about it. But from where I'm standing, it's very glary, but that's probably that laser beam there. They cause the eosinophils to survive and proliferate. So this is a pro-eosinophil factor. Interleukin 13 is going to have profound effects on smooth muscle. It's going to cause proliferation and enlargement of smooth muscle. So interleukins 4, 5, and 13. 4, 5, and 13. Now, the first thing that will happen is that the eosinophil will go to that pseudostratified ciliated epithelium, and it's going to damage it. These secrete certain types of proteins that are very damaging to cells like that. These cells are going to get damaged. This is going to become denuded. So you'll have to have proliferation in order to heal it, but you'll expose these nerves, these sensory nerves. That's going to cause you to have this burning, irritating feeling. You're going to want to cough, and it's going to be very, very uncomfortable. All right, so with allergies, you will remember the mast cell, which is a basophil type cell, gets born in the bone marrow and then leaves the bone marrow, circulates, leaves circulation, finds a cool spot to hang out and just hangs out. That's a mast cell. Mast cells have special FC receptors on their surfaces. Remember what the FC region of the antibody is? Who does? Who doesn't? Most of you. Okay, let's review the FC receptors of antibodies using our little makeshift blackboard here. All right, there we are. So an antibody has 2 heavy chains. Oh, that's ugly. And 2 light chains. 2 heavy chains, 2 light chains. Heavy chain, light chain. It binds the antigen here. So this and this, these are the antigen binding sites. This piece here, if you clip this from the rest of the antibody, it crystallizes. So this is called the fragment that crystallizes, or the F sub C portion of the antibody. This binds to receptors on the surfaces of cells. So these cells have receptors that recognize this particular part of the antibody, and these sit in the cell membrane of the cell, and these receptors, so that is an FC receptor. These are specific for each different isotype of antibody. So there are IgG specific FC receptors. There's IgM specific FC receptors. Mast cells carry an FC receptor that's specific for IgE. Does that help? That knock some cobwebs loose? Good, okay. And I forgot to, okay, I just, some folks didn't see that, darn it. There. So again, Zoom folks, here's your antibody. Here's the antigen binding site up here. This piece here, that's the FC portion. This is called the FAG portion, the fragment that binds the antigen. Sometimes it gets called FAB, which that led to lots of jokes when I was in graduate school. Fab is an old name of a detergent. There's a detergent, used to be called Fab, doesn't exist anymore, but we used to call this the detergent part because it was named after this detergent. And it was a cheap detergent, so us poor college students could afford it. So anyway, the FC portion is here. This binds to these receptors that are embedded in the membranes of cells. And mast cells have a FC receptor for IgE molecules. All right, back to the ranch here. So on mast cell surfaces, these cells bind IgE when those IgEs bind allergens and the antibodies are cross-linked, the mast cell will dump its granules. These mast cells are full of granules, and those granules contain things like histamine. Histamine works very quickly. It causes smooth muscle constriction in your bronchial tubes. That causes you to wheeze. Histamine works quickly, goes away quickly. Then it has other factors that last longer, like leukotrienes. Leukotrienes don't act quickly, they act later, but they act for a long time. And they're very powerful constrictors of the bronchial tubes. And they summon white blood cells to the area as well. So you get bronchoconstriction and airway obstruction. The other thing these factors can do is they increase mucus production from goblet cells. So now, think about this with me. Here's your bronchial tube. Now you're doing this to it, and then you fill that up full of mucus. Not going to be able to pass air through it? No. No. That's why people who have asthma describe themselves as suffocating. As suffocating. It's an obstructive disease of the respiratory tract. This simply shows you the different antibody subtypes. The star of the allergy and antibody, allergy and asthma show is immunoglobulin E. That's induced again, B cells are induced to isotype switch to make IgE because of interleukin 4. Because of interleukin 4. And so the mast cell dumps its payload full of histamine, tumor necrosis factor alpha, leukotrienes, and a few other things. The main ones are histamine and leukotrienes. Here is a very high resolution picture. This is an electron microscope picture of a mast cell. And after it degranulates, you see the membrane ruffles, and then all these granules full of histamine and stuff get dumped. And that's essentially how you have this allergy. Now, eosinophils normally are there to fight parasite infections, but asthma illicitly activates them. And so now these will go after your epithelia in your bronchial tubes. And that's why these eosinophils can be so deadly in cases of asthma. All right, so you get denuding of the epithelium, you expose the nerves, they're irritated, that induces coughing, bronchoconstriction, which will cause wheezing. You're now going to get a condition called dyspnea. Dyspnea. Dyspnea simply means difficulty breathing. Dyspnea. So the first modification that occurs in the respiratory tract is that the damage causes fibrosis, repeated damage causes fibrosis. The basement membrane starts to thicken. As the basement membrane thickens, you're going to lose some of the diameter of that bronchial tube. So the basement membrane starts to thicken. That's the first thing that happens. Basement membrane thickens because these fibroblasts are activated by various growth factors made by eosinophils, Th2 cells. Also, the damaged cells here are going to release chemokines that will activate fibroblasts. They will thicken the basement membrane. Next modification is you get hyperplasia and hypertrophy of the bronchial smooth muscle. Morgan, what's hyperplasia? Very good. Pat yourself on the back. Increase in number of cells. Increase in number of cells. Anna, what's hypertrophy? Increase in size. The cells get bigger. So both of these happen due to interleukin 13. Both of these happen. What do you think that's going to do to the airway diameter? It's going to cinch it down even more. Then you get increased blood vessels. This is due to angiogenic factors like vascular endothelial growth factor 1. These are released by the invading white blood cells that are constantly being summoned into this area by this irritation that goes on. And you get neovascularization. That's going to further narrow the diameter of the airways. And it further thickens the walls of the bronchial tubes. Next, you get hyperplasia and hyperactivation of the goblet cells. You get more goblet cells, and those goblet cells secrete more mucus. So now you've taken the bronchial tube, you've increased the extracellular matrix, increased the layers of smooth muscle, increased the layers of blood vessels, and now you fill that smaller cavity with a lot more mucus. It's going to be impossible for air to get through that. So this essentially, as you can see, is stage 5. So each stage occurs progressively. If you don't treat asthma, you will get this modification and it'll be permanent. Once you get to right about here, it's getting to where it'll be harder and harder to reverse it. Here, it's reversible. When you get to here and here, it's now permanent. So by treating the asthma and reducing incidence, asthmatic incidence, you decrease the tendency for this remodeling of the airways. Do you see now why treatment is so important? All right, let's continue. Are there any questions before we move on? Yep, okay. Now, in response to allergens, histamine will be the first culprit. That'll be your early response. Leukotrienes will mediate the later response. That will usually come a couple of hours after the initial response. That's why someone can pop in antihistamine. They'll feel fine, but then hours later, they'll start to clog up again. That's due to the fact that leukotrienes now are taking over and are mediating that response. The nerves that innervate the smooth muscle that surrounds the bronchial tubes is innervated by the vagus nerve. Their neurotransmitter is acetylcholine. Therefore, acetylcholine will promote constriction of that smooth muscle. Is this a potential place where you can block constriction of the bronchial tubes? Sure it is. And what you're going to use are inhaled anticholinergics. Inhaled anticholinergics. These drugs usually won't have a lot of systemic absorption. Because they won't have much systemic absorption, they won't have the systemic effects that most other oral anticholinergics might have. Now, the relaxation of the smooth muscle is promoted by norepinephrine. Norepinephrine binds to a G protein coupled receptor and activates the synthesis of cyclic AMP inside those smooth muscle cells. So cyclic AMP inside those smooth muscle cells will promote relaxation. So what if you were to prolong the half-life of cyclic AMP inside those smooth muscle cells? Would you promote dilation, relaxation and dilation of the bronchial tubes? Sure you would. Sure you would. So this essentially is how the drug theophylline works. Theophylline is available orally and parenterally. It tends to work very fast. It unfortunately has a narrow therapeutic window. This drug can cause some serious arrhythmias if you go above the maximum levels of theophylline. But if you really have a patient who has refractory asthma, theophylline is a potential add-on you can consider. It inhibits phosphodiesterase type 3 and will promote bronchodilation. Theophylline also, as you can see, will bind to adenosine receptors. By binding to adenosine receptors, it's going to block bronchoconstriction as promoted by adenosine. Your antimuscarinics, your muscarinic receptor antagonists, will antagonize acetylcholine and therefore will prevent bronchoconstriction and will promote bronchodilation. Inhaled antimuscarinics are the treatment of choice for COPD. Let me say that again. Inhaled antimuscarinics are the treatment of choice for COPD. Paige, what's COPD stand for? That's exactly what it is. Chronic obstructive pulmonary disease. You will see that in people who are lifelong smokers. You will see that in people who worked in factories where there was a good deal of debris and dust that is very dangerous. People who worked in shipping, for example, people who worked in coal mines or other types of mines who didn't wear protective respirators, they will tend to have chronic obstructive pulmonary disease. All right, are there any questions about the pathophysiology and the physiology before we get into the meds? Because you'll see, once you understand that, you'll understand right away how the meds work. No? Okay, folks on Zoom, don't type questions, just say them, because if you type them, I'll probably miss them. Do you guys have any questions on Zoom? No? Then we will soldier on. Okay, you can give certain treatments prophylactically. These prophylactic treatments are preventative. So there are two drugs that will prevent mast cell degranulation. Because they prevent mast cell degranulation, they prevent triggers. These two drugs are cromolyn sodium and nadocromol. Cromolyn sodium and nadocromol. These are inhaled, usually. They're inhaled by means of an MDI, meter dose inhaler. By the way, never, ever assume that just because your patient has an MDI, they know how to use it properly. There was a study that came out of, I think, University of Illinois at Champaign that showed that almost half of the people who used either an MDI or a DPI, a dry powder and inhaler, didn't use it right. So if you're wondering if medicine is working, have the patient demonstrate the use of the MDI. You'll be surprised how many people try to play it like a trumpet or something like that. I had one person tell me the story. I'm not sure I believe it, but she said the patient literally would go like this, like that. Yes, Karis. Yes, it's quite shocking. But now, the very first time I ever was prescribed an inhaler, literally, I picked it up and I looked at the pharmacist and I said, I don't know how to use this. I've never used one. How do you use it? And she gave me a very nice little tutorial on how to use an MDI. It's not hard, but it's not always obvious. Don't assume it's obvious. Don't assume it's obvious. Train somebody and have a nice little video online on our Blackboard site on how to use an MDI, how to teach people to use an MDI. MDI, again, is metered dose inhaler. Metered dose inhaler. Now, if you have intractable asthma, standard treatments will not work, then you're going to go to a biologic. One of the best biologics, if you have asthma that is triggered by allergies, is this drug here, omalizumab. Omalizumab, or Xolair, is a monoclonal antibody against immunoglobulin E. It binds immunoglobulin E and prevents it from binding mast cells. So it takes immunoglobulin E out of commission. It's injected. The company is making a home injector. The home injector is not yet approved, FDA approved. Usually now you have to go to the doctor's office to get this. Usually you have to get this about once every month, once every 6 weeks, something like that. These shots are really expensive. They're $1,000 a shot. But for people with intractable asthma, this medicine can give you a new lease on life. It's very well tolerated. For intractable asthma, refractory asthma, it's sometimes called. But it has to be asthma that is triggered by allergies. That's the type of asthma in which this will work quite well. Also, this drug works quite well in children. And it is given to children. Very safe in children. Omalizumab. Again, when you say MAB at the end of a medicine, that means it's a monoclonal antibody. MAB means monoclonal antibody. So this takes out circulating IgE. You don't get it binding to mast cells. Therefore, mast cells don't signal to eosinophils. You don't get the infiltration of eosinophils. You don't get mediator release. You don't get asthma attacks. You don't get damage. You don't get remodeling. Questions? This is administered SC, sub-Q. So these two meds, cromolyn sodium, natocromyl, for some people they definitely work, but on the average, these are not medicines that work all that well. So these are being prescribed less and less. And most of the allergists I've talked to have said, for asthma, I wouldn't use them. But for allergies, seasonal allergies, I'd use them. So that's what the allergists have told me. Cromolyn sodium is very cheap. Oh, there's a myth online that says cromolyn sodium causes cancer. It's rubbish, complete rubbish. Mice, as they get older, are more prone to cancer. So if your experimental group outlives the control group, the experimental group will get more tumors. And that's what happened in that paper. The experimental group lived longer, so they had more tumors. Wasn't due to the cromolyn sodium. All right. Now, drugs that will block interleukin-5. There's 3 of them. So first, there's benralizumab. Benralizumab blocks the interleukin-5 receptor. The interleukin-5 receptor. It is also a monoclonal antibody. This is for people with refractory eosinophil prominent asthma. Eosinophil prominent asthma. People with eosinophil type asthma tend to not have good relief from other types of drugs. These drugs will relieve their asthma, and they'll relieve it quite effectively, and they're usually able to get off oral steroids. So benralizumab prevents signaling by interleukin-5. It also marks the eosinophils with an antibody. So now these will be killed off by antibody-dependent cytotoxicity. And so natural killer cells will come in, and your eosinophil counts now will go back down to normal. These 2 drugs Rislizumab and mepolizumab bind to interleukin-5 and prevent interleukin-5 from interacting with its receptor. Mepolizumab comes as a pen, an injector pen that patients can self-inject. Rislizumab has to be given IV. You have to go into the doctor's office to get a bag of rislizumab. So it's not as convenient as mepolizumab. So this goes by the trade name Nucala. This goes by the trade name Syncare. That goes by the trade name of Fasenra. These drugs are newish, they're antibodies, and they're very expensive. How expensive are they? Okay. Benralizumab. Cost of a single treatment of benralizumab is $5,000. So insurance will not pay for this unless you've tried everything else and it doesn't work. Then they'll pay for it. Mepolizumab, one treatment is $3,000. Rislizumab, one treatment is $2,800. Not cheap. Not cheap at all. So benralizumab, your first treatments are every month. Then after that, after the first 3 treatments, then your treatments are every 2 months. Mepolizumab, your treatments are every month. Rislizumab, your treatments are every month. And this just shows you the difference of function between these two. Another drug that now is also being used for atopic dermatitis is dupilumab, which goes by the trade name Dipizent. Dipizent or Dupixent or however you say it. This is also an antibody, and it binds to a common polypeptide that's shared by the interleukin-4 and the interleukin-13 receptor. So it blocks both interleukin-4 and interleukin-13 signaling. This also comes as an injector pen, so the patient can self-inject. And this shows you how that works essentially. So this alpha subunit is shared by both the interleukin-4 and interleukin-13 receptors. Dupilumab binds to this, prevents the cytokine, the interleukin, from binding. That is also used for refractory, intractable, asthma. How much does that cost? So let's see. This one, you need to be dosed every 2 weeks, and a month's worth of dupilumab is $3,100. Yeah, not cheap. So the so-called Liberty trials, in people with moderate severe asthma, 12 years and older with the eosinophil type asthma that's resistant to treatment, that decreased asthma events, decreased serum IgE, decreased blood eosinophil counts, increased lung function, decreased dependence on oral steroids, reduced markers of inflammation, and the drug is well tolerated. Hey, kind of a win-win there, isn't it? Well, what if your asthma is treatable? You should have been given an algorithm treatment algorithm for asthma. It's got the steps on it. Looks like this. Guys all get that? Yes, good. Okay, you guys on Zoom, if you have that, can you please pull it up? Now, in order to understand this algorithm, we need to be able to classify the different types of asthma. So get that sheet out too that says asthma classification. Asthma classification. So the first type of asthma is mild intermittent asthma. In this case, you have episodes essentially less than twice a week. And again, this is not seasonal. I can't emphasize this enough. Nursing students often think allergies and asthma are the same thing. They are not. They are not. Allergies are mediated by mast cells only. Asthma is mediated by the immune system and eosinophils and Th2 cells and what have you. All right, so mild intermittent asthma, you don't have a lot of change with your labs. So your peak flow really doesn't change. And your FEVs, your forced expiratory volumes. Did you guys do an FEV lab in AP? No? That's a shame. There are these FEV devices now you can blow into. The doctor's offices they have a mouthpiece that's removable. And with kids, it's fine. They get to take home the mouthpiece. Anyway, they take it and you inhale as deeply as possible, and then you blow into this, and then the FEV1 is the forced, it's a volume of air you expel over 1 minute, 1 second. FEV1. That's a really important measure for asthma. The other is the peak flow intensity. Peak flow intensity. Doctors' offices have peak flow meters. I'm sure you guys have seen these. They're this big. They've got a little mouthpiece, and they're kind of shaped like that, kind of. There's a little gauge on it. You blow into it, and then the gauge goes like that, and it locks to reset. Then there's a button, you reset it. Oh, okay. Dude.
But it's not, it doesn't like you move the slide the thing to like the back, but.
Okay. Did you steal it from a doctor's office or?
No, I think we got it a while ago. Me and my brother had it.
And you outgrew it. Okay. Yeah. That does happen. Okay. So those tests are very useful and they're extremely easy to do. And they have a peak flow meter up at the field house. Maybe I'll steal it. Well, borrow it. 5-finger discount. And bring it in and just show you what it looks like. Also on your rotations, ask if there's a peak flow meter that you guys can look at and say, oh, my pharm professor is an idiot and he wants me to see what this thing is. It's an assignment. It's something. If I don't do that, I'll come back and I'll get yelled at. And I can't stand being yelled at. Blah, blah, blah. Ask if they have one and have them get it out, show it to you, and then you can take a look at it, and it's quite easy to do. Have any of you used one on a patient? You will. If you work ED, when you guys work ED, you will. People come in, chest is tight. First thing you do is hand them a peak flow meter. Okay. So this, nighttime symptoms less than twice a month, no symptoms between flare-ups. That's mild intermittent. These folks usually just need a bronchodilator that they use PRN. So it's a beta 2 agonist, and on your medicine list, that's your albuterol, levoalbuterol, so on and so forth. Mild persistent asthma. Now I have nighttime symptoms almost weekly. Now essentially almost every day you're having an event, and now your flare-ups affect activity level. Circle that. Flare-ups affect activity level. Once you're into flare-ups affect activity level, now you're in a mild persistent asthma. The asthma is not intermittent anymore, it's persistent. And now you're going to look at inhaled steroids.
Would that be like considered use asthma? Or are you saying that it's effective?
It affects the things they like to normally do. Say they like to go for hikes, but they get up, halfway up and they're heaving and breathing and wheezing and what have you. Some people get exercise-induced asthma. And so they'll get, we had a hurdler who had exercise-induced asthma. She only got it when she went really fast, which you have to do when you're doing hurdles. And so she'd take a puff. She got approval from the NIAA to take a puff before a race, take a puff, and then get in the blocks and then go. And then by the time she got around and jumped all the hurdles, by the time she ended, she could feel that she wasn't quite right, but because she had the puff before, she was fine. All right, moderate, persistent. Now flare-ups affect normal activity level, and now your FEV starts to fall to below 80% of normal values. And your peak flow is now down significantly, more than 30% variable. And then severe persistent asthma, you're essentially having symptoms frequently. And your activity level is really compromised because you're always dealing with asthma. And your FEV is below 60%. That's the big number, 60%. You're below that, you're severe persistent. All right, so now that we have that down, we go to the algorithm. We can see here with step 1, mild intermittent asthma, that's just going to be short-acting beta 2 agonists. Short-acting beta 2 agonists. And they're used PRN. Pro, res, nata, Latin for use it whenever you want. Literally, or as the need arises. But nobody studies Latin anymore, so nobody cares. Let's take a break. Take 5, and then we'll come back, talk about the treatments for allergies. Then we'll get into the medicine list. Make sure you have this handy, because we'll go over that. Okay? 5 minutes. Okay, Zoomers, 5 minutes. Okay.
Yeah. Yes.
Nice.
Last week.
Really good.
Yes.
She played a lot.
Yeah, I
A
was.
lot.
We lived up in College, I guess. Yeah.
Oh, yeah, but, yeah,
Yeah, that was cool.
yeah, she's very nice. Her dad's really good at it.
Yeah.
Yeah. So, wait.
Yeah, she's gonna be doing
Yes, yes, so, she was very concerned about grades of volleyball players and their grades,
Yeah.
so. I hope she comes, I think she's finding a home here, yeah. She wants to get out of Seattle. She likes Seattle, but she just wants something different. My impression is that she doesn't want big city. She wants small. Because when she mentioned the colleges she visited, they were all small town colleges. Yeah, so. Sorry? Oh, yeah. You're a model of faithfulness. So one year, we had a student who had a birthday. Our wife made this little cake for them. We had cake all cut up, it was nicely frosted. We didn't have any candy.
Are you kidding me?
So I went to the lab and I got a few tips.
You tip on the cake?
And we put it in, we let it. And it went like this, whoosh. Just burned like that, so. Lots of things to get to this weekend.
Hey, if it works, it works.
Start straight. She was just grateful for the table.
Right, nobody's gonna.
What's the other thing on there?
Dr. Lee, do you get allergies?
Yeah, all of them, all of them. I'm violently allergic to all of them. And I went down to UC Davis is the olive capital of California.
Oh.
So every April when the olives would start to come, I'm and then a few molds, just a few molds and stuff like that. So.
My sister's went through allergy testing, like a little pricks on their back.
Yeah, or in the arm.
Yeah.
Yeah.
And they found out there was no microphone, so that's it.
I had an allergy test, before they have the little automatic striker thing. You go through, she originally made a syringe and scratch it out. Good painful.
What, the allergy test?
Yeah,
It hurt. I got one when I was little.
And, they use a little, thing with little grill pet thing on a machine that does it and it, like that. This lady didn't have those, she was just rinsing it.
Oh. They look hurt.
Yeah, it
I didn't
hurt.
know they were supposed to hurt, and now when I felt soap, and then I was like, oh yeah, it's like needles. I was like, that's,
Yeah. not pleasant. Okay, time to resume. Now, for seasonal allergies, your mainstay treatment will be your antihistamines. There's two types of antihistamines. The first generation drugs, which are old and are very effective, but these drugs are lipid soluble. They will cross the blood-brain barrier and they will inhibit the H1 receptor in the brain. What does the H1 receptor in the brain do? They're part of the reticular system, which are responsible for alertness. So when you suppress the H1 receptor in the brain, you cause drowsiness and sedation. That's why some people take these as sleep aids. That, by the way, is a bad idea. So that is a large side effect of these drugs: drowsiness, sleepiness, sedation. Also, some of them have slight anticholinergic effects. So if you take them at night, you may have trouble with urine retention. Your bladder may have trouble opening up because of that. Now, because of this, these are usually not recommended. Your second generations are all water soluble. They do not cross the blood-brain barrier. They're extremely safe. Fexofenadine is on record one of the safest drugs around. It's virtually impossible to overdose on that drug. It's very safe. Loratadine, also very safe. Nasal Astin is only available as a nasal spray. It's not available orally. And cetirizine, which is now in a generic, was formerly called Zyrtec. Third generations, these are still in license. You have desloratadine, that's Clarinex, and then levocetirizine or Zysel. There's really no reason for these because these are usually just as effective. So stick with second generations. Many of these are available over the counter. They're not that expensive. They're very effective. So recommend those to your patients. Try to dissuade them from taking diphenhydramine as a sleep aid. Diphenhydramine, because of its anticholinergic effects, tends to disrupt REM sleep. REM sleep requires acetylcholine. When you disrupt acetylcholine, you disrupt REM sleep. So it may help you get to sleep, but your sleep quality is much poorer. Also, after taking diphenhydramine for a couple of nights, it won't work. Your body becomes tolerant to it. So there are better sleep aids than these. Don't go there.
Why don't we just get rid of this generation?
Because for some people with really severe allergies, these are very effective. So what was the one that I used to always take as a kid? Oh, I forget the name of it. Anyway, oh, this one, chlorpheniramine. I still remember April, I was in a virology class with Randy Pritchett. Holy Hannah, that guy was boring. He had this rare talent for taking a fascinating subject and making it as dull as rocks. And I had taken some chlortrimeton and I kept falling asleep in my notes. I had to write and then you could see my pen go like this when I fell asleep. Because they're just, because that stuff just knocked me out. It was awful. Victoria? Yep. That is the case in children. In some children, it does the opposite of what it does in adults. Probably because of its anticholinergic effects. Now, other neurotransmitters that acetylcholine regulates now are upregulated, and those can overstimulate children. That can happen in adults too, but that paradoxical stimulation, as it's called, is more common in children. All right, your methylxanthines includes theophylline. This is used for emergencies, and it's used for hard to treat cases. Do not give this drug to children long term. It'll cause learning disabilities. And yes, caffeine is a methylxanthine. So will caffeine tend to treat asthma to some extent? A little bit. So if you need to get something before you can get to the drugstore and you're wheezing, can you wolf down a cup of coffee? Sure you can. Will it help? It'll help just a little, but it won't relieve your asthma. Yeah, Shay? Do not give it to children on a long-term basis. You can give it to them acutely. Don't give it to them chronically. Will cause learning disabilities. If you're giving it to them for asthma, usually this drug is layered on top of many other drugs. So for example, step 4, that's essentially, or 3, those are the places where you'd introduce theophylline. Instead of theophylline, you'd want to introduce a leukotriene receptor antagonist or beta-2 agonist tablet or something like that. Or you'd want to up your dose of inhaled corticosteroid or something like that. For allergies, you'd want to use probably cromolyn or Singulair or something like that. Very good. So your beta-2 agonists are your first line for that intermittent asthma. These are inhaled. They come as short-acting beta-2 agonists, SABAs, or long-acting beta-2 agonists, so-called LABAs. And those essentially are what you will use to relax those bronchial tubes. So your short-acting beta agonists, those are to relieve symptoms. Those are the rescue drugs. You will have a rescue inhaler. The rescue inhaler tends to have a cap that is red. When the pharmacist dispenses it, all rescue drugs will have a red cap. That's how, if they need their inhaler, they need something in a hurry, they don't just sit there and read labels. They just grab the one with the red cap. These drugs do not quell inflammation. They don't knock down inflammation. If you have someone who all of a sudden tightens up and they can't breathe, they're going to pass out, epinephrine. I am epinephrine. If they're prone to that, they should have an EpiPen. And when sung to the tune of Alouetta, you should sing epinephrine, epinephrine, epinephrine. Take it in the leg, because the leg is the biggest muscle. First you take a little bite, then you get a giant fright. Start to heave, pressure leaves. Gotta heave, syncope. Oh, epinephrine, epinephrine. Epinephrine, take it in the leg. Oh. No. Okay, so, see, you will never forget. So, EpiPens, it's clear, EpiPens are underused. A lot of people who need them doctors won't prescribe them. So they're underused. Now you can get a plastic practice injector. Pharmacies have them. They'll give you them for free. And jamming them in the leg can seem pretty scary for parents or for the kid themselves. So if they practice with a practice injector, that will that'll help. They're plastic and they're very non-threatening looking. So these usually you put them on the leg and you just push and it goes and you get instant relief. Insulin is given sub-Q. Glucagon. Glucagon you'd give IM. They have needles, yeah. Yep. But it's an emergency. They get a bee sting. They eat walnuts or something, or peanuts. You know. Sorry? No, the practice one, it's all plastic. No, you're not going to cut some, but no. I have one upstairs. In fact, I brought it to Micro once and I said, you guys need to wake up. Remember, I used it to wake you up. You don't? Maybe I'll bring it. I'll bring it down next time and show it to you. Right. Okay. So your drug of choice is albuterol for short-acting agonist. Albuterol is very cheap. Generic albuterol, a MDI, is about $20, thereabouts. With the coupons you can get online, the MyRx coupons, you can get it probably for $10. And then sometimes you can get other discounts, you know, maybe be less than $5. So those are very cheap. Levalbuterol is under the name Zopanex. That drug is more specific. So it's lower dose, it's more active, it's a little more expensive, but it works better for some people than albuterol. These two drugs are long-acting beta agonists. They're used for control. They're not used for rescue. They're used for control. So SABAs are used for rescue. LABAs are used for control. Good? Long-acting beta agonists nowadays are virtually never used on their own. They're always combined with inhaled corticosteroids, or they're combined with something else. If you use them on their own, the tendency to die from heart-related activities, heart-related issues, the risk goes up. It's small, but it goes up. If you combine them with other drugs, that risk is more or less abated. All right, your muscarinic antagonist. Yeah. Onset for a rescue is half a minute, if that. It'll last usually up to about 4 hours, probably 6 hours tops. The drug insert says it'll last till 12 hours, but all the allergists I'm friends with on Twitter have said, albuterol lasting 12 hours? I said, well, it says that on the insert. And they said, and you believe the insert? I said, well, no, but that's what it says. They said, yeah, that means that's the most it'll last in exceptional people. Now, what does it last for everybody else? It will last usually 2 to 6 hours, something like that. Your long-acting ones will last about 12 hours. Muscarinic antagonists, they're better for long-term relief. You don't use them for short-term relief. They help to dilate. These also do not treat inflammation. And inflammation is a thing you really need to treat. So ipratropium is short-acting. It lasts 4 to 6 hours. Tiotropium is long-acting. It lasts 24 hours. So this is long-acting. This is short-acting. And these antagonize muscarinic receptors in the lung. Very good. Okay, if you take your algorithm and you look at step 2, you'll see that your drug of choice is an inhaled corticosteroid. An inhaled corticosteroid. The inhaled corticosteroid is dosed between 200 to 800 micrograms a day. These will treat inflammation. These are inhaled. They're active at the site of inhalation. Their half-lives are such that they tend to break down once they're absorbed systemically. So you get very little systemic side effects unless your dose is really high. So these work very well. If these don't work, then you go to oral steroids. And oral steroids have, we've talked about this before, lots of side effects. So even though oral steroids can be very effective, you don't want people to be on it long term. There are just too many side effects. Then you have your leukotriene inhibitors. These bind to the leukotriene receptor and antagonize that receptor. These are your 3 drugs that will fight inflammation. So here are your inhaled corticosteroids. Definitely the one that's used the most is fluticasone, the one up there. That's definitely the one that's used the most. Budesonide gets used a good deal. And so does, there should be no H there, mometasone. Mometasone. Oh, there were those really charming commercials with a bee that was voiced by Antonio Banderas. Yeah, for mometasone. I love those commercials. They're very charming, I thought. Yeah. Dexamethasone is not used so much for asthma. That doesn't come in an inhaled form. These do. These do. Your oral or injected steroids include prednisone and methylprednisone. You use these if you're just not getting the relief you need from inhaled corticosteroids. And you can see step 5 in your algorithm, use daily steroid tablet in lowest dose providing adequate control. So that is, you get to the end of the road, you have to use that oral steroid. Leukotrienes are very potent neutrophil chemoattractants. They're also very potent constrictors of bronchial smooth muscle. They cause mucosal edema, mucus hypersecretion. These are the different types of leukotrienes. Leukotriene B4, C4, D4, E4, so on and so forth. And the drugs that treat these are montelukast, zafirlukast, and xylitol. Zafirlukast is used in Europe, not used in the US. Patients on zafirlukast tended to have liver trouble. Well, a percentage of it had liver trouble. So that drug was discontinued. Montelukast is the one, that's the one that goes by the trade name Singular. Singular. Xylitol prevents leukotriene synthesis. It interferes with leukotriene synthesis. This drug, unfortunately, has been linked to cases of drug-induced liver disease. It's available in the US, but it's rarely used. The one that's usually used is montelukast. Montelukast. So there's your little flow chart. Xylitol inhibits this drug, this enzyme here, lipooxygenase. And then the receptors here, those are blocked by montelukast, zafirlukast. And then prostaglandin synthesis is inhibited by NSAIDs. And the enzyme that liberates arachidonic acid, that's what gets inhibited by glucocorticoids. That's why glucocorticoids quell inflammation. And there's zafirlukast, montelukast, hirulukast, therulukast, hirulukast. Questions? Very good. So remember, you start with a combo of low dose inhaled corticosteroid with your beta-2 short-acting agonist. If that doesn't give you relief, then you add on top of that. So again, you're layering drugs. You're layering drugs to try and achieve control and prevent remodeling. That's your goal. So you add the long-acting beta agonist with the low dose inhaled corticosteroid with the rescue inhaler as well. If there's no response to the long-acting beta agonist, then you up the dose, you stop the LABA, you up the dose of the inhaled corticosteroid. If that doesn't work, you then up the dose to essentially the maximum dose available. And then you add more drugs. You add leukotriene receptor inhibitor. You add sustained release theophylline. You add maybe a beta-2 agonist tablet, which terbutaline is a beta-2 agonist that comes as a tablet. Then if that doesn't work, you go to oral steroids. And if that doesn't work, then you go to a biologic. You go to omalizumab. You go to benralizumab, resralizumab, mopilizumab, dupilumab, those drugs. Usually, if you're not getting relief there, you'll go to an asthma specialist. All right. Very briefly, let's just look at the drug list. So we went over the short-acting beta agonists. Long-acting ones, you have formoterol, formoterol, salmeterol, and olodaterol. Again, these are usually combined with other drugs. So they're combined They're combined with corticosteroids. They're combined with anticholinergics. There's lots and lots and lots of these combination treatments available. They're all available by prescription. Okay. Methylxanthines, theophylline is the one that comes usually as a tablet. Aminophylline, which sounds like an ancient Egyptian city, that comes as an intravenous product. That you'd use in the ED. If someone comes in, they just can't breathe. Anticholinergics. So your fast-acting one is ipratropium. Then you have aclidinium, which is long-acting with tiotropium. Umeclidium, which is also long-acting. And then this is combined with olidaterol, tiotropium, or umeclidium is combined with bilateral. Bilateral is a long-acting beta agonist. Then the rest essentially are things you might buy over the counter. So guaifenesin, that's Mucinex. That's available over the counter. That's an expectorant. Inhaled acetylcysteine. That's used by people with multiple sclerosis to break up mucus. You can use it too. It's available as an inhaled form. DNase, that's used mainly for people with multiple sclerosis, cystic fibrosis, sorry. Then you get your antitussives. Antitussives are for, this is where you answer? Cough, thank you. In Spanish, a cough is tos. Tosar is to cough. So that's from the Latin, tussus, to cough. So antitussive, anti-cough. Codeine is a very good anti-cough drug, but that, unlike what you have in Europe, has to be by prescription. You can get low-dose codeine in England, for example, over the counter, not here. Tessalon, which is benzonatate, that's available by prescription. And then dextromethorphan, which is in tons and tons and tons of different cough syrups. Then you have things that are combined with various types of opioids for really bad allergies. These are available by prescription. They contain codeine, so on and so forth. I won't read you the riot act on all these, just so you know. Some of these, look, they're Schedule 3, Schedule 5, Schedule 2, Schedule 2, Schedule 5, Schedule 3, blah, 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 blah. You get the point. Your antihistamines. So here's your first generations. These are all available over the counter. Don't need a prescription for any of these. Second generations. Azelasten, you get by prescription. All these others, the oral, are available over the counter. These drugs here are ocular drugs only. They're used for allergic conjunctivitis. Allergic conjunctivitis. So olopatadine used to be marketed as Patanol. Now it's called Patadine. And then ketotifen, that is available over the counter. Both of these are, therefore, those red bloodshot eyes you sometimes wake up with during allergy season. Decongestants, these are nasal decongestants usually. A word about alpha-1 agonists that are nasal decongestants. You use them for 5 days tops. If you use them longer than that, your nose starts to become dependent on them. So no more than 5 days. Then your mast cell stabilizers. We went over those. Your interleukin-5 antagonists, moplizumab, reslizumab, benralizumab. Your anti-interleukin-4 receptor antagonist, dupilumab. Your interleukin antagonist, in fact, the only one you'd be responsible for here is montelukast. These others, you'll never use them. Then your corticosteroids. So some of these are available over the counter. Fluticasone is now available over the counter. So is budesonide. That's Nasonex. Nasonex, I think, is the name of that. Cyclicinide. Cyclicinide is an interesting drug. That drug is a specialty drug because it gets broken down in the lung. So it's never absorbed systemically. It's a very safe drug. And then I just have a bunch of the different combo drugs. So fluticasone and salmeterol, budesonide, formoterol, Symbicort, Advair, and then you have Trelegy Ellipta, which is 3 drugs, blah, 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 blah. You get the point. All right. That is asthma. Are there any questions about anything we've discussed? Wednesday, we'll start on GI drugs. So I sent you a handout about the difference between ulcerative colitis and Crohn's disease. Bring that with you on Wednesday. And we will cover Clarissa's favorite group of drugs, GI drugs. Okay? Don't forget the quiz. It's due before midnight. A lot of you haven't done it yet. Please don't forget.
Medication calculation papers due within the semester. And if you have an IV drip, and it's like, say the age is like 10.4, do you round up or do you round down? For like drips per minute.
Usually we're gonna round down. If the doctor wants the medication in, if there's a time limit, say they're gonna have surgery the next day, they have to have all this in them, then they may say round up.
So like, I mean, it's like regular rounding, like it's over 5.
Usually
or
down.
like
Usually down.
usually down all the time?
No, if it's below 0.5,
Okay.
down. It's about 0.5 usually. Round up unless you're dealing with something where getting too much of it is really going to be an issue. So it'll feel, depends on the drug. And yeah. So if it's, 17.3, 17. 17.8 by 18. Yeah. Oh, for what?
For the focus freeze and the science seminars,
Yeah.
I was wondering why I only got an 80.
Did 3 focuses. So that's 60. Natural science seminar.
Yeah.
1, that's 20, that's 80. Yeah. Did you do more than 1 science seminar? How many did you do? You did two. So. I only have one email from you about seminars.